Ashish Bajaj. I am a consultant at SNC Chitrakoot. So we'll be starting this session, which is on diagnostics and planning in cataract surgery. The first speaker, Dr. Richa Agarwal, IOL power calculation formula, customized approach.
Good afternoon, everyone. Thank you, AIOS, for giving the opportunity to talk today. So I'm going to talk about IOL power calculations. Nowadays, the goal of surgery has changed from good visual outcome to good refractive outcome. So that is actually where the role of good IOL power calculation comes in. So according to this study in 2017, there's still room for improvement, as most surgeons even nowadays able to achieve the best target of 0.5 diopter in mostly 80% of the cases, and only a very less than 2% of the patient surgeons are able to achieve a target of more than 92%. So with newer methods, this target of 90% is still achievable. The newer biometry devices, which has now improved to like the latest IOL Master 700 with faster acquisition, improved keratometry, and less reliance on ultrasound A scans, and increasing the number of parameters to improve the effective lens position helps us in increasing the IOL power calculation accuracy. So the IOL power formulas can be classified based on generation, which is now obsolete. A more practical classification of IOL formulas is on the basis of the principle, which is a historical or regression formula, which are now obsolete. The Virgin's formulas are based on Gaussian optics, which can be divided further depending upon the number of variables they use, either 2, 3, or 5 or 7 variables. Then there are ray tracing formulas. Example is Olsen formula, and nowadays artificial intelligence formulas which combine regression analysis and neural network. Example Hill, RBF, and Kane formulas. So the recent studies also shows the comparison of these newer formulas as compared to the older formulas, and they tend to perform better than the older formulas. Why were these older formulas imperfect is mostly because of prediction in the error in the prediction of the effective lens position. Older formulas generally use two variables, that is axial length and keratometry. However, they tend to work well within the normal eye range, that is normal axial length and normal keratometry. But whenever the measurement falls beyond the normal range, the formulas they don't tend to do better. So we need to increase the number of parameters to be fed in to increase the accuracy of effective lens position. So one of the parameters that is most important is the anterior chamber depth, which nowadays most of the newer formulas are using, and there are other optional formulas which are also available, increasing the accuracy of the newer formulas. So the newer formulas which I'll talk about are Barrett-Sweet formula, Olsen formula, EVO, Hill, RBF, and the Kane formula. The Barrett-Sweet formula is a combination of 5 formulas. Barrett Universal 2, which is for non-toric IOL calculation with keratometry values. Barrett Toric for toric IOL calculation. 2K is for post-laser vision correction formulas. And Barrett TK is for total keratometry, which is nowadays used in IOL Master 700. This is the free interface, Barrett-Sweet interface, which is available free online and can be used for IOL power calculation. Barrett Universal 2 is more than just a formula, as in you can see that in the picture, all these Hagees, SRKT, Holiday, they are single line code formulas. But Barrett Universal 2 is a 3000 line code formula and is still evolving formula. It is based on theoretical optics, Gaussian optics, as well as on artificial intelligence, and it uses up to 5 parameters. So increasing the number of parameters which are fed into Barrett's increases its accuracy. Various studies comparing the Barrett's with the older formulas, Barrett tend to perform much better than the older formulas. Another formula is Hill RBF, which is considered a method, not a formula, as it is based on artificial intelligence algorithm. The RBF stands for radial basis function. It is a mathematical model that combines pattern recognition and data interpolation. It is used in facial recognition and sensitive softwares like fingerprinting, etc. It does not rely on usual optical principles. Hill RBF version 3 is now available, and since it is based on adaptive learning, the more the data is fed into it becomes more accurate. So this is again freely available online software, which is version 3 available now. Kane formula, which is the newest formula based on theoretical optics, regression, and the artificial intelligence, and it is applicable to all excellence, and it is found to be superior than other formulas, even Barrett 2 and Hill RBF we are talking about. However, it is still not suitable for measuring in post-refractive cases. So multiple published clinical studies have proven Kane formula to be more accurate in all cases, including the Barrett's 2 as well as Hill RBF. There are two large studies, including 18,000 patients and 10,000 patients, which have proven the Kane formula to be superior to these other formulas. So this study by Melissa in 2019 showed the Kane formula to perform much better in across all legs illness. So that is the most advantage of the Kane formula, is that it performs really well in long as well as in short eyes, especially in the short eyes, because the study in JCRS published in JCRS showed that patients with IOL power of 30 diopter or more, in that Kane formula perform much better than Barrett's 2. And as we always said ki Hofer Q should be used for the shorter eyes, that is not the case. Hofer Q is one of the worst performing formulas. We should use Kane formula or Barrett's 2. So what is to be used in longer eyes? In longer eyes, the problem is overestimation of exit length. So this overestimation, initially when we were using Holiday 1 and SRK2 formula, there was Wong-Kop method of adjustment which had come, but this is also not a very good adjustment, which we nowadays we should avoid, and which we should use Barrett's Universal to Hale RBF or Kane formula. Another method in longer eyes is to use the biometer Argos, which uses segmental measurement of the exit length. So for long eyes, the best methods are using Olsen, Barrett and Hagees, and to avoid Holiday and Hofer Q, and otherwise we can use Hill RBF and Olsen formula as well. For shorter eyes, what is the problem? Even a minor error in the prediction of ELP causes a major change in the IOL power. So shorter eyes is a major problem with calculation of IOL. So which is the IOL formula which has performed in various studies performed better? As I already mentioned, Hofer Q is one of the poorest formula which is to be used for shorter eyes. Always use Barrett 2, otherwise we can use Hill RBF and Kane formulas. They tend to perform better. So across the various AC depth, various keratometry and various exit length readings, the formula that tends to maintain its accuracy is Barrett's. So special circumstances like bag versus sulcus implantation, every surgeon now or the other time do fall into this scenario when we cannot implant the IOL in bag. So in that case, we cannot just go ahead with our same IOL power. We need to calculate the IOL power, recalculate the IOL power. That is because number one is because of change in the effective lens position, and second because of the change in the IOL material or the IOL A constant. So the Warren Hill has given this adjustment. Depending upon the IOL power, you subtract other minus 1.5 when the higher IOL powers are used, and you subtract 0.5 when the lower powers are used. So even after perfect calculation and using the biometric device and best IOL power, refractive surprise still happen. So a coefficient is required which can be used to adjust the IOL power calculation of the other eye. So that prediction that is 50% of the prediction error. So there are two major studies which have covered this, what should be the optimum adjustment coefficient. So according to the IOL formulas, the adjustment coefficient is changed. So if we're using Barrett Universal 2, 0.3 is the adjustment coefficient, and other formulas are mostly 0.5 adjustment coefficient is required. So to summarize, most surgeons up to 80% are able to achieve the best target, that is 0.5 diopter. 92% is achievable with modern methods. The best optical biometer, that is SWEPS OCT, is now available and should be used with minimal limitations. The newer IOL formulas like Kane, Barrett, Olsen, Hill RBF should be used for all range of exit lens, and we should be careful when we are implanting the IOL in sulcus and not in bag. Thank you.
Thank you, Dr. Richa. Any questions from the house? Okay. So, I assume you have used some of these formulas,
Yes, sir.
and your endpoint is of Barrett.
Barrett's, yes.
And though it would be a slightly off the topic, but how about the machines which give you a Barrett's? Any comparison between the machines you have?
So we have IOL Master 700, so that is one of the best machine. We are using Barrett's 2 on that. Barrett's 2 actually it has the advantage because it is using multiple parameters, not just 2 parameters. So maybe people who are using still ultrasonic biometers, they will say that there is no advantage of using a Barrett's. But however, there are studies who have compared that even with 2 parameters, Barrett's perform much better than the older formulas. So going with Barrett's is always better, whether any machine you're using.
Another interesting thing which I saw was with Keynes, one of the 5 parameters was gender.
Yes, sir.
So how does gender come into picture in the entire formula?
So it is not actually exactly. I tried to read it in detail, but I couldn't find it. But I think because of the anatomy of the eye, the relation between the antechamber, the relation between the axial length, that is because of the correlation.
Is there any information regarding the same key? Lady, female and male have different AC depth relationships. Is there something like that in literature? I'm not aware of that.
So I couldn't find that when I was reading about the Kane formula, but I was just guessing that is where the gender is coming to.
Okay, but it was there, so it was
yes,
that was the most interesting
yes,
part of it. Thank you.
Thank you.
Actually, for sulcus implantation, something known as the rule of 9, what you said, it's fine. But if you are going to capture the IOL in the rexes, then you don't need
then
to
you
change
don't
the
need the
IOL power
adjustment.
because the
Yes,
ELP remains the same.
Yes, sir.
So you should keep in mind if you are going to capture the IOL, don't change the IOL power.
Yes, sir. That is one important point.
Sir, in biometric chromatic eye, it is okay to use the K value of the other eye if there is a corneal tear, you have repaired it and you have a chromatic cataract. Then what formula do you use to calculate that?
So we use either the K value of the other eye, or we generally use the K value of the eye because this eye has caused. If we are able to calculate the K values of this eye with astigmatism, we use the K value of the traumatic eye. But if not able to calculate the K value because of the opacities, because of the quite damage to the cornea, then we tend to use the K value of the other eye.
Better to use a standard K, sir. The keratometry of both eyes can vary. So we use a standard K, 44 and 44.5 or 44 and 45.
If axial length is same, if axial length is same or the things are same ACD,
Yes, we can also compare that way, yes.
And some formula they are using CCT, male, female also. So one ESER's website, you can put the data and 4 or 5 formulas there. So they will give you what will be the IOL power. So then you can compare it. Barrett is the best, Barrett Universal 2 is the best. But still you want to go, then if extreme of eye, you can go to that ESER's website. Multiple formulas are there, put the data, they will give according to EVO, Barrett, all these formula. What should be the IOL power.
And the other important thing is the biometry. If you are not doing a good biometry, you give any formula, won't help. So applanation biometry is out of question. If you are doing a immersion scan, do it well. Because everybody might not be having this optical biometer. So it's imperative to do a very good this immersion scan.
Thank you, Doctor. Can we have the next speaker? Dr. Archana Chaudhary is here. Please.
Thank you.
Her topic is patient selection and conditions in toric IOL. Dr. Archana, please.
You can use a lens star. Yeah. The new lens star. Good evening, everyone. Thank you and gratitude to all the members and the organizers of the midterm Dehradun AIOC. My topic is patient selection and calculations for the toric IOL. As we know that the toric IOL practice has in the recent years has increased, and the modern day cataract surgery is a refractive surgery. So precise planning is the most important factor here. Toric calculations, once done well, the results are very gratifying and we have happy patients. So an ideal case selection is prerequisite before the surgery to ensure patient satisfaction and to give optimal outcome. Ideally, a patient for toric is where the vision is compromised by cataract, he has regular astigmatism, and there are no major ocular comorbidities. That is, any case where we can do phacoemulsification is our patient for toric IOL. So here we are killing two birds with one arrow. We are treating cataract as well as astigmatism. Absolute contraindications would be irregular astigmatism, zonular instability, some complications with the capsule while operating, if we have a tear. So we definitely need a stable capsular back complex for the rotational stability of the IOL. Relative contraindications would be poorly dilating pupil. We surgeons are now highly skilled in even doing mid-dilated pupils also, but we can also use the dilating devices like the BHEX, the Maluing rings, or the iris hooks. Then the other contraindications are patients undergoing the VR procedures, any glaucoma surgeries. So any patient where the vision is compromised as well as the macula, if the vision improves more than 624, we can still consider to do a toric IOL. Patients with progressive fleshy pterygiums need to be operated first, and then we can wait for 6 to 8 weeks to go in for a cataract with toric. And now the other contraindications, the keratoconus, Fuchs dystrophy, corneal scars. Also, we need to give some time to the patient and see him on the slit lamp for a while to rule out dry eyes, any ocular surface disorders, and other meibomian gland disorders too. So the indications is regular astigmatism where two principal meridians are 90 degrees to each other and the cornea is uniform. Patient counseling here is again very important. Patient's expectation is a subjective factor. We should understand what the patient needs, what his profession is, what his hobbies are, as well as the patient needs to know what is the outcome after his surgery. So any unrealistic expectations should be dealt now. Patient needs to be educated about astigmatism, about what is toric IOL, how it is different from a regular monofocal IOL. And also, if we are planning a monofocal toric, then he needs to be understood that he will need near vision correction. And if he is wishing to have a spectacle-free life after surgery, we need to counsel him for a multifocal or a trifocal toric lens. So the lenses available, they are from 0.75 to 4.75, which will correct sphericity from 6 to 34 diopters. We also have extended series and customized toric IOLs for higher power. Ultima Smart is one of them, which makes for us. So the first test before for evaluation after we have done the external examination and the fundoscopy would be keratometry. We all know that total dioptric power of the eye is cornea plus the lens. Here the lens is the cataractus, so we need to know our anterior as well as our posterior corneal measurements. Multiple measurements should be done by separate devices based on the different principles, and these could be manual keratometer, automated keratometer, placido-based corneal topographer, shuntling, imaging system, and OCT-based system. If there is any variability between both the devices, we have to evaluate for coexisting ocular morbidity. So we have the anterior cornea and the posterior cornea. Now we know that the posterior cornea also acts as a concave lens, and it gives us some amount of steepness, about 0.5. Anterior cornea with the rule astigmatism in younger people can shift against the rule astigmatism in older people. And so if we do not take in consideration of the posterior cornea, we are going to be having a lot of surprises after the surgery. We can have increase in with the rule astigmatism and decrease in after the rule astigmatism. So both anterior and the posterior cornea measurements nowadays can be done in most of the latest biometers, and these ideal formula, they will include the SIA, the posterior corneal curvature, and the effective lens position. The SIA is, most of us know our SIA, and it is the amount of astigmatism that we will be leaving after the surgery. And usually in the micro-incisional cataract surgery that we do nowadays, it's about 0.1 to 0.2, or we can go ahead and calculate it on this website, that is crcalculator.com. So basically, the Barrett toric calculator is the what everybody needs to know now, and it uses a universal 2 formula, and it has a I think Dr. Richa has also said about this. It considers axial length, keratometry, ACD, lens thickness, and white to white. Also, it is freely available on the ASCRS website, where we can just go and fill in the data, the patient's data, the steep and the flat axis, and we can get our axis of alignment. And this is also available with various companies, the individual IOLs that we are using. So this can be easily done. Image guided system is a Virion at the Callisto that can be used for preoperative planning, which will give us the location and the size of the surgical incision as well as IOL positioning. Then we have the iTrace, which combines the placido-disc corneal topography, and it will help us with preoperative as well as postoperative assessment in cases undergoing IOL implantation. It also has an inbuilt toric planner, and it helps us to calculate the power. So take-home message would be reduction in astigmatism is critically important because it can result in significant improvement in visual acuity. But educating patients with astigmatism is important. My talk is on patient selection. So we have to utilize some patient educational material like some brochures or vision images. And lastly, implanting a toric IOL is an art, and we surgeons are the artists. Thank you for the patient hearing.
Any questions from the house? Sir.
In the toric IOL, 2 errors are there, which we are not even able to predict. One is SIA, and second is PCA. So how much is the PCA? Though we are using that Barrett nomogram, these formulas are integrated in that formula, Barrett toric calculator, but still their measured PCA is something different, and so these are the 2 errors.
Yes. So as it is a lot of experience, I think that goes in hand, and most important thing is after the calculations are done properly is also the way we've implanted the lens. I mean, making a good capsular axis is also important so that it covers 360 degrees the IOL. Washing out the OVD is another step to do, and maintaining a good anterior chamber depth till the end.
So for SIA, just I want to say a few words. Incision SIA, we can't predict because when we take incisional temporal incision, either the axis will rotate or the flattening or steepening of the cornea will occur. So we can't predict it. So Dr. Barrett, he's saying that don't increase the size of incision, go for 2.4 or less than that, and take the incision SIA value 0.1 for your incision. Go for a smaller incision and take the value of 0.1. So for incision SIA or 0.2.
Nice presentation. I just want to highlight, sometimes if you have a few 2 or 3 devices and your keratometry readings are not matching, then it will be a better idea to defer the toric IOL, or you go into the Barrett formula and there is a total K, so it has a provision, you put in all the readings and it gives you an average K, but still you are not sure that the patient is going to benefit from the toric IOL. Other thing is the contraindications which you talked about, ma'am. I think so small pupil you can do toric IOLs, but it's a relative contraindication. The only problem you have with small pupils is that you might have a problem in aligning the IOL. Otherwise you can do it. And keratoconus, I am not a cornea surgeon, but a lot of them say that if the keratoconus is stable for the last say 1 year, you can go ahead and do a toric IOL once you have done a C3R. But I don't know if you can just...
If the patient is using spectacles, a keratoconus patient, and he's stable and he's happy with the spectacles, he might be happy with the lenses as well. If
Can you sum it again?
Saying, is there a problem if the patient has asteroid
if the vision you think can improve more than, if you can give him that quality of vision more than say 624, then you should go for it.
toric IOLs are not as notorious as multifocal IOLs. So even the toric IOL is forgiving. Even if you will implant a toric IOL, it won't matter much. But multifocal IOLs, asteroid hyalosis, if you are doing a multifocal toric, don't do it with asteroid hyalosis.
Yeah, and if you're doing a multifocal, then even a small error should be corrected and multifocal toric should be implanted, because then the patient will not be happy. He's going to be paying a big amount for your multifocal lenses.
I have a question from the panelists. So what are your cutoff values for the amount of astigmatism when you're planning a premium IOL surgery for choosing a toric IOL? Like for how much astigmatism would you plan a premium, like a multifocal or an EDOF IOL? Would you plan a toric one versus a non-toric?
It actually depends upon what astigmatism you are dealing with. If you are dealing with the rule astigmatism, you can up your threshold, what the Baylor
So
norm.
how much would you?
We do toric IOLs after one diopter of astigmatism. If you are say having astigmatism of 0.6 against the rule, you add up 0.5 so it goes to more than 1, so you do a toric IOL. If you are having with the rule say 1.5 or 1.2, subtract the against the rule posterior. So you can go and just give the incision in the steep axis and you can get away. So it depends upon what you are dealing with. If you are dealing with the rule, you may up your threshold to 1.5 say. If you are doing against the rule, bring it down to 0.7. So it all depends what anterior astigmatism.
Most of the cataract patients will have ATR, so
Enter your
even
data.
if you're planning a trifocal or multifocal, better even if you have a 0.75, you should do a toric.
The easiest option is once you know that you're going to insert, I think incision wherever you're going to take, put it on the toric calculator. If you're suggesting a toric
Enter your data in the Barrett toric calculator. Net astigmatism is written there. last.
Basically,
So it is
threshold.
more than 1, then you can go. If it is less than 1 and it is against the rule, you can take 2.8 millimeter incision. It will decrease some to 0.234 diopter. So it's okay.
Threshold has to be lower when you're using a premium lens like a EDOF or multifocal. If it's a monofocal, you can probably stretch it to 1.5 or more. But for these, because you want to deliver an uncorrected vision, your threshold has to be low. Yeah. Another point for keratoconus, you were talking. In keratoconus patients, you can certainly use toric lenses, but you have to look at the topography. Make sure it's largely regular and the Mayas are not greatly skewed. If it's very skewed, then you can get an unpredictable result. So look at that, and if you've got one of the advanced topographers, you can look at EKR map and all that.
You are doing serial topographies
Yes.
before you decide.
And of course, it should be stabilized by cross-linking or natural stabilization. And formula-wise, K in keratoconus formula is the only specific formula for keratoconus. Otherwise, SRKT is the other one which works reasonably well in keratoconic patients.
Thank you.
I will invite here dynamic
Thank you so much.
from Mumbai, Dr. Rohan Mehra.
His talk is in. He will be talking on planning to incorporate toric IOLs in your practice. All you need to know.
A very good evening to one and all. Welcome to Dehradun. So today my topic is going to be To incorporate toric IOL in your practice, all you need to know. So we're going to be dealing with the absolute bare basics of toric IOL and how a youngster or somebody who is experienced and hasn't taken up toric in their practice can do so. Welcome to Dehradun, and I would like to thank the staff back at my hospital who have helped in some or the other way in making this presentation. The most important point that ma'am also mentioned in her talk previously is patient selection. So if we are planning to go ahead and do and give a wow factor to our patients post-op day one, we have to be sure that we have chosen the patient who would appreciate that wow factor in the first place, right? If we don't choose that patient who would appreciate that wow factor, all of your planning, all of your execution will go in vain. So what about the patient selection? You have to go methodically. Vision, manifest diffraction, a thorough slit lamp examination, dilated fundus examination, optical biometry, a topography. It should be regular, stable, and symmetric. Current evidence suggests that the minimal amount of corneal astigmatism of approximately 0.75 is to be corrected. So as sir was mentioning before, if you have a regular bow tie astigmatism, that is going to be the most suitable. An irregular astigmatism is a relative contraindication. It is shown to be effective in patients with irregular astigmatism, including keratoconus, pellucid marginal degeneration, and post-keratoplasty eyes, if on the pentacam the EKR values from 2 millimeter right up to 6 millimeter are pretty much the same, and there is not much more than a 0.5 jumping of the values from 2 millimeter to 5 millimeter of the cornea. So toric IOL calculator. So you have now selected the patient that would appreciate the fact that you're putting a toric IOL in the eye. Now you go ahead with the calculators. There are all sorts of calculators that are available. Each company also has their own calculator that is there. So you have the online calculators. You need to determine your own SIA, as was mentioned in the previous talk, and include PCA. So this is the universal sort of a Barrick calculator that you can use for any lens that you are putting, any brand that you're putting, because the algorithm of the Barrick calculator has the most amount of data that is there. So you have the patient ID, you can choose any of these lenses that is there, and this is how the printout of what you're going to be implanting in the eye is going to come out. So in this particular case, you can see it's the left eye, and the calculator is telling you to implant it at 174 degrees. So now that your calculation is done, you see that what is the toric power that is to be implanted. You see at the left corner there is the T2 to T9, and you have different lenses, different companies, all of them from T2 to T9 will be different. So you need to customize it for your particular patient according to the lens that you're going to implant, according to the brand that you're going to use, that which one from T2 to T9 that is the one that you're going to be using. So the advantages of the Barrett toric IOL calculator are very easy to use, takes into account the posterior cornea as well. It also considers lens position for each individual patient versus using what is known for the average eyes in a lot of formulas. Lens thickness is measured, which helps in even better predicting. So the thing is that some people say, I don't have an optical biometer. Now, can I go ahead and do a toric? Yes, of course you can go ahead and do a toric. The more data that you will enter in the Barrett's formula, the more accurate your result is going to be. But that does not mean that if you don't enter everything, you're going to get a very, very inaccurate result. So if you don't have lens thickness, for example, if you don't have an optical biometer which is giving you a proper ACD, you can still omit the ACD part of it. You can put the lens thickness from your contact, you can put it from your immersion, and you can have all that data into the system. It will still give you what angle, what degree it is meant to be implanted in. So this is how the Technis toric calculator looks like. You first basically select the eye. You give the K notation whether you want it to be in diopters or millimeters. You make sure you have the correct eye. Once that is done, you enter your SIA, you enter the axis and the incision. As was mentioned, the incision that you take plays a huge role in toric surgery. You can always alter your position. You can sit superiorly, you can sit superior-temporally, you can sit temporally, depending upon where the steep axis is. Once all this has been entered, you take your readings from whichever K machine that you are using, either the ARK, that also works fine if you don't have a topographer. And then you'll get something like this. This is the final result that comes in, and it tells you how much of the residual astigmatism will be left behind. So here then you choose. You see here at the bottom, you choose which one do you require, which one are you going to be implanting. This again depends upon how much residual cylinder is going to be left behind. So now that you have done the calculation, you have chosen your patient. What next? So next is going to be the instruments for marking the toric. So this is a typical instrument marker, the set that is required. So what we do in our practice is we do a two-step procedure. First we do it in a sitting position on the slit lamp in the OPD, and then again on the table. So we do it in a two-step manner so that errors are omitted. You can choose, you can use these markers. You can mark your axis marking rings with these markers so that the imprint stays onto the cornea. The axis marking has to be in upright position to prevent cyclotorsion. The cyclotorsion of the eye, just a second. Anyways, the upright position to prevent cyclotorsion. The cyclotorsion of the eye from the upright to the supine position is approximately 2 to 4 degrees on average, but can be up to 15 degrees in individual patients as well. So the three-step marking procedure, the first is pre-op, the second is again pre-op, marking at the limbus at the horizontal position with a sterile ink pen or a needle. You can use a 26 gauge needle as well, but initially I would say you use a marker and not a needle, but once you do get a hang of it, then you start using a 26 gauge needle. The third step is intraoperatively on the table. We have the image guidance systems also, but even in these systems, it has now been determined that in a lot of these, what happens is that if, for example, the blood vessels that have, the machine has taken into incorporation to have this axis that it is giving you, if that blood vessel becomes skewed, then this can go haywire. So it is always a good idea to even mark this manually, even though you have the Virion system. So the sources of errors can be an error in planning, error in measurement, and error in execution. Errors in planning can rule out causes of irregular astigmatism, as I mentioned earlier, comparable magnitude of axis of astigmatism on refraction, biometry, and topography. If these are not matching, that's a red flag sign. Consider posterior corneal astigmatism as well and use aberrometry where possible. So this is a very important slide, errors in measurement. So you see all these machines are there. We started way back with this, what used to be the gold standard for a very long time. Then we went on to the IOL Master 500, which took about 6 points of measurements. Then we moved on to the Lens Star, which takes about 16 points of measurements in the center. And now we have moved to the swept source. So are all these machines the same? Well, there are errors in measurements in all the machines. What is most important is, you see this, how this makes a huge difference. We let our technicians do these tests for us. We don't do it ourselves. So you see just the position of the chin, just the position of your head, how much error it causes. Same patient, 1 minute apart. On the top you see an astigmatism of 0.9, in the middle you see an astigmatism of 1.4, and at the bottom you see an astigmatism of 1.9. Same patient, 1 minute apart. What was different was the position of the chin, position of the head. So this is extremely important, because this error, you can't predict it, and you won't be able to solve it later on as well. So errors in execution, of course, errors in marking. When you do it initially, there can be an error that can happen initially. So you need to be very careful that the patient is cooperative on the slit lamp when you're doing the markings on the sides. To summarize, online calculator, reference marking, rexis marking, axis marking, alignment, rotation, and vaulting. Most important, patient selection with what I started with. If you do a toric calculator and you end up having an issue, you end up that the toric has rotated, there is this website called astigmatismfix.com. You can go to that website. It's not like, for example, if the toric has rotated by 10 degrees or 12 degrees, you can go back into the OT on post-op day 2, day 3 and rotate it back to that. No, you can't do that. You have to go to astigmatismfix.com. So I have basically just taken this screen recording for you. So what happens here is that you enter all this data. Once all this data has been entered, you click on calculate. It takes into account a lot of things. It takes into account the cylindrical power at the corneal plane, what the current IOL access is, and also takes into account what the current refraction of the patient is post-operatively, how much of astigmatism is the patient accepting now post-operatively. Once you've entered all that into your astigmatism fix, then it will basically tell you, you click calculate and it will tell you how much you're supposed to rotate it by so that the patient gets clear vision. So these are a few commercially available IOLs that are there in the market. Thank you so much.
The most important thing as a beginner, I think so, is that the message across is you don't need many fancy gadgets. It's how you are going to do the keratometry. So it's always advisable to do the keratometry first thing when the patient comes. After you have done all the contact procedures, you're going to get an erroneous keratometry. Second thing is, through a manual keratometer, you look at the Myers. If the Myers are circular, you are most probably, and both the axes are at 90 degrees, you are dealing with a regular astigmatism. So you can go ahead and do a toric, because PCA is already incorporated in the Barrett's formula. And in CN, you can always shift according to how close you want to go to the steep axis. And marking is beautifully highlighted. So there's one app actually available known as iToric. Once you do the marking, you just go, it's a mobile based app. So you just click on that and it will tell you how much of your marks have missed. So how much do you need to realign that? Suppose you are supposed to align that IOL at 6 degree and your 0-180 degree has missed by 2 degrees, it will tell you automatically. So it's a very good app, the iToric. You can use it once you have done the manual marking on the this slit lamp. Just it's a mobile based app, it will click a photograph and tell you how much you have deviated. Any other questions?
Another thing is the head tilt.
Yes.
If there's a head tilt, usually there's a lot of intorsion, extortion, so you measure the axis of the sleep axis wrongly. So that is something that we look at when you are visualizing.
Right. Thank you, Dr. Mehra. Can we have a next speaker, Dr. Desai, Abhijit Desai, who will speak on use of monochrome filters in cataract surgery? And the next talker is Dr. Sinha. We have him here.
So, thank you so very much for having me over here, and it's a wonderful organized meeting. So we are going to talk about monochrome cataract surgery. Is it here to stay? So when you photograph people in color, you photograph their clothes, and when you photograph them in black and white, you actually photograph their souls. I'm a great fan of black and white photography, so that's something that I would actually like you all to see now. So this is basically on Ingenuity, which is a 3D heads-up surgery, and we incidentally found out this filter called the monochrome filter. We were just trying some different things, and we realized that because of the change of the entire high dynamic resolution into a single tonal value, you get an enhanced glow and an enhanced contrast in certain steps of cataract surgery. Like this is especially done in rhexis. You can see the hydrodissection wave much more enhanced than what you would see in color. So we tried doing the phacoemulsification also in the same filter, and I didn't find a big difference, but my colleagues did not like it during the phacoemulsification, and that goes with the studies which have said that, yeah, probably the depth perception is not that great in phacoemulsification. So if you're looking at polishing the capsule, we're looking at doing the irrigation aspiration, the minutest details and the specs are seen more enhanced in this particular filter. So it helps you in cleaning the capsule much better. So this is the alignment of the toric IOL which we have done. This is just another case in which I am showing how the specs can be seen and cleaned with more efficiently with using the black and white filter. I'm going to skip a few things and show you the difference between the sudden contrast change that we get. Now here, when I change into this particular filter, you can see up here, there is a very small peripheral rent out there. And you can actually see the fibers of the vitreous in the same, because of the high dynamic resolution. So the contrast values help you discern between even the viscoelastic that you would use and the vitreous. So here, in such a difficult situation, because of the visualization, I am able to do a PCCC in that area also. So here I am going to do a PCCC out there in that area. And then do a vitrectomy. And now you can see the difference between the viscoelastic and the vitreous. So the viscoelastic will be stable with waves, and the vitreous will be the one which will have fibers, and they will have both different tonal values, and you can actually see the difference in the tonal values out there. So the indications where I use monochrome is basically cortical cataract, CCC, hydrodissection, cortical wash, especially in femtocataract, wherein it's very difficult to discern the cut edge of the cortex, posterior capsular polishing, difficult cases like anterior optic capture, and many other things in which you want that contrast to be much better, CTR insertion, PCCC, anterior vitrectomy, and cataract with corneal opacities. In fact, you get you can do enhanced moonlight phaco with these kind of cases. So what do you do when the glow fails and you don't have the dye, or you hate the dye? So this is a case in which it's a cortical cataract, and I realize that I'm not able to see it there, and the moment you change it into a black and white filter, you will suddenly see that enhanced thing, and you'll be able to see the entire rexus margin very easily without using a dye. Thank you for watching the soul of the cataract surgery. Thank you.
Excellent presentation. I just wanted to ask whether this filter comes as an inbuilt, or you have to buy it separately as an attachment.
No, this is on the Ingenuity, so
Yes.
that's the software. So it's
We have recently acquired Ingenuity, but
Yes.
I've done only 3 or 4 cases on that, but I didn't know that this also exists.
so this is a wonderful thing for these particular indications. So it works pretty well.
So it's an inbuilt filter.
Yeah, it's an inbuilt filter.
Other thing is, when you have a PCR with vitreous loss, so you don't need to use triamcinolone now if you're going to use this filter.
Yes, but you can use triamcinolone. It enhances that as well, the stain and everything. The only issue with the filter is the blood vessels are not seen. So it blanches out the entire limbus. So for the main incisions, you still need to go into color.
Thank you so much.
Next we have Dr. Satyajit Sinha with the premium IOL in patients with cataract and PXE.
After the beautiful video by Abhijit, we'll now talk about premium IOLs in cataract surgery in patients who have pseudo-exfoliation. I would like to thank the scientific committee. I'd like to thank all of you for being here, and the chair over here. In my practice now, I've almost totally shifted to offering my patients either these trifocal IOLs or EDOF IOLs. Unless otherwise warranted, I'm not giving my patients monofocal unless otherwise they cannot afford at all. But I always give them the option of EDOF, and we have cheaper Indian companies are also making very nice EDOF IOLs which are much cheaper, and the trifocals are also by Indian companies. So more or less, I've shifted to premium IOLs, and the patients are very happy. And slowly a time will come when your patients will come and tell you that they want a EDOF IOL and they want a trifocal IOL, because right now the patients are pretty confused of what is premium and what is a regular IOL. But that day will come soon. And in your practice, you will come across these patients who will have pseudoexfoliation. And as we all know that the zonules are weak and we have to take special care in these patients. The most beautiful things in the world cannot be seen and even touched. They must be felt with the heart. And what am I talking about is the zonules behind the iris which you cannot see. And especially in these cases of pseudoexfoliation, when you don't see the zonules and you are seeing the pseudoexfoliative material on the anterior capsule, on the iris margin, it is best to put a CTR in these patients. Several studies have shown of the entire IOL bag complex descending into the vitreous many years even after the surgery, especially in cases of pseudoexfoliation where adequate support techniques were not used. Because even when we are doing the surgery, we are putting the stress on the zonules. As it is, they are compromised from before, and we hurt them more and the zonules become even more weaker. There are several reports have shown that CTR implant reduces the intraoperative complications of pseudoexfoliation eyes, suggesting the use of device in cases of mild zonulopathy and phacodonesis. While these pseudoexfoliation cases have several complications can happen preoperatively, intraoperatively, and postoperatively, we will now focus on the IOL in the bag dislocation, which is one of the most dreaded complications which can happen, especially in pseudoexfoliation in total IOL in the bag dislocation. There are weakened zonular apparatus. And why are we so concerned? Because even on that day when you're operating, when everything goes smoothly and the IOL is right centered in the bag, still it's a progressive zonulopathy. Once you have seen the thing on the IOL, on the iris margin, once you have seen the exfoliative material on the anterior capsule, remember that this is a progressive zonulopathy, and even if everything is all right today, that's not a guarantee that tomorrow things will not be all right. There may be capsule rupture and there may be zonular dialysis also. The degree of zonular laxity does not strictly correlate with the amount and extension of the pseudoexfoliative material visible over the lens, but more with the age of the patient. The more the patient is older, the zonules will be weaker in addition to what was happening with the pseudoexfoliation material which was there. The typical signs of zonular weakness are phacodonesis with eye movements and sometimes a reduction of the anterior chamber depth due to forward shift of the lens, which we are all aware of. In addition, there is increased weakness of the zonular apparatus. There is limited pupillary dilatation at times. There is more risk of vitreous loss, several times higher, especially from the sides it can come. So once you are operating these patients in the operating room, these things should be available right at that point of time, like high molecular viscoelastic device, the iris retractors, the ring dilators, and the capsule tension ring. And at that point of time, once you feel that the bag is constricting or contracting, and that time if you look for a CTR and the CTR is not available in your OR, the things can become quite disastrous. And all these things, if you use, it reduces the risk of intraoperative complications. As I said, there may be vitreous loss, there may be nuclear luxation, there may be bag decentration, and dislocation of IOL with the time. This video was not running properly. So, though the CTR may make it difficult, surgeon must use a capsular tension ring to support the capsular bag during cortical cleaning and IOL implantation. Once you see the capsule is contracting and you still have some zonules, some cortex remaining, it may be a good idea to put the CTR, especially in these patients who have pseudoexfoliation. Those who do not have pseudoexfoliation, you can put the CTR later also. But once you are doing the stripping of these cortex in patients who have pseudoexfoliation, it's a good idea to put the CTR even before removing the cortex. Otherwise, you may pull the whole bag together because the zonules are weak. Tangential stripping in combination with gentle centripetal traction should allow accurate cortical removal. And in case of extensive zonulopathy dialysis, more than one device may be employed is required. The capsule retractors help support the zonular lens complex in the anterior-posterior direction for facilitating hydrodissection and cataract fragmentation. while the CTR allows even distension of the capsular bag, supporting areas of zonular dehiscence by redistributing the zonular tension, allowing optimal IOL centration. The capsular phimosis with IOL decentration and late IOL in the bag dislocation are among the most dreaded complications occurring after the surgery, which is why CTR is so important. And capsular shrinking determines centripetal traction on weakened zonules, including tilt and decentration of the IOL with possible dislocation of the IOL bag complex. Now, the choice of the IOL implantation in pseudoexfoliation patients, it is related to the elevation of the state and the future risk of capsular instability. In presence of zonular weakness following a CTR implantation, a one-piece or a three-piece acrylic IOL may be implanted as per the surgeon's choice. IOL capture is also a good idea where it is unpredictable for future instability, which is always an issue. In these patients, we also have to keep in mind that there is increased endothelial cell loss in patients who have pseudoexfoliation, and there is also a chance of cystoid macular edema, so use of NSAIDs is also a good idea. Thank you so much for your patient hearing.
Thank you, sir. Very nicely put. Actually, in pseudoexfoliation and all generalized zonular weakness or zonulopathies, as you rightly pointed, CTR is a must.
Yes,
because later on you are going to have a capsular phimosis. Other thing is the timing of the CTR, as you rightly mentioned. So if you are dealing with a relatively harder cataract, it is better to put a CTR early because the chopping forces are going to further increase the zonulopathy. But if you are dealing with a relatively softer cataract, you may delay the CTR because CTR itself is going to cause a lot of problems like difficulty in rotation. Cortex aspiration becomes very difficult because then you have to use more of the tangential stripping forces.
Yes.
So as somebody has rightly put in that the CTR should be put as late as you can but as early as you must. So yes. So I've read it somewhere. It was a video on YouTube where they very beautifully had said this, that so CTR is one thing which is important, and then as you rightly said, what IOL you are going to put. So what is your take on putting multifocal IOLs in these patients?
Patient expectation is very high, especially in these days. But if you see a patient with pseudoexfoliation, it may be a good idea to avoid multifocal IOLs, trifocal IOLs. It is not a good idea to put in these patients, and you can explain to the patient that to use a conventional monofocal and use glasses after the surgery.
Another thing, a lot of studies are going on these days, is that people, they put a CTR in the bag and then they put a three-piece IOL in the sulcus and capture it. So then the bag is not going to dictate the turn. The IOL gets locked in, so you have a longer term stability.
Yes.
So it's a good idea if you're putting a monofocal IOL, put in a CTR in the bag and put a three-piece in the sulcus and capture it.
Yes.
So long-term stability is much more than
Yes, yes. I mentioned that.
Thank you, Dr. Sinha.
Thank you very much.
Can I invite Dr. Amit Kumar Mahajan? Is he here with us? And Dr. Sachi Vora? Dr. Rajinder Kumar Gupta or Dr. Pushpak? Dr. Gupta is here. So he will be talking on pearls to achieve perfect capsular access in different cases. Thank you, sir.
I say good evening to everyone because it is now 5:45, and I am thankful to scientific committee for giving me this opportunity. My talk is very simple and it's on pulse to achieve perfect capsular axis in difficult cases. Obtaining a perfect capsular axis is a vital component of any cataract surgery. A well-centered capsular axis with 360-degree overlapping capsular edge prevents IOL tilt and optic decentration. In complex cases, the capsular axis is even more critical, and sometimes it can determine either the success or failure of your case. Cases where perfect axis is challenging, like wide and hypermature cataract, intumescent cataracts, Morganian cataracts, subluxate lenses, traumatic cataract, pediatric and posterior polar cataract. While we are doing capsulorhexis in a mature cataract, so always stain the anterior capsule with the trypan blue. It enhances the visibility of the anterior capsule, and always use high molecular weight viscoelastic to keep the AC formed throughout the procedure. Now in the first video, it is very old video where I used to do capsulorhexis through the main incision, and but the problem is that after this capsulorhexis is going in the periphery. So what to do now? So I again injected the viscoelastic, and then with the Utrata forceps I completed the rhexis because it is more controlled than the cystitome. And the direction of tear should always be towards the center. Then this video is 3-year-old video where I used to perform the rhexis through the side port. Because the chamber stability is more, chances of leakage of viscoelastic is also less. So always keep your forceps upwards towards the cornea. Chances of leakage of viscoelastic will be very less. And with the microrhexis forceps, we can do the rhexis. Now again there is a problem. So actually bad habits are very difficult to die. So I again introduce my microrhexis forceps through the main incision. And because I was more confident with the main section. And anyhow, I completed the rhexis. And it's a beautiful rhexis, see. Again, 2-stage capsulorhexis is a beautiful technique. So what you have to do to make initial puncture, and then after making the initial puncture with the forceps, you make very small rhexis, that is 2 to 3 millimeter in shape, size. After making this, you have to remove all the liquefied cortex with the help of Simcoe cannula, and you can do the milking of the anterior capsule as well. Today Dr. Harbans Lal shown one video there, and he said that even without puncturing the capsule you could reduce the pressure. So that is also very good technique. Then with the, after making the small rhexis, you cut it with the, with the Vanna scissor, and then with the help of capsulorhexis forceps, we can make the rhexis. Because intralenticular pressure has gone down, so it's like making a rhexis in the normal cataract. You don't need any fancy needles or other rhexis, type of rhexis. Then one more type is the spiral rhexis, and in this case what we have to do, we first raise the flap, initial flap, and then you have to go into the spiral manner. You go on increasing the rhexis, and that is also the good way of doing rhexis in the mature cataract, and you can complete the rhexis, very nice 5.5 millimeter rhexis without any problem. This rhexis I have learned from Dr. Mohan Rajan. He used to do it, and it is known as puncture rhexis. So in this rhexis, what we make the initial puncture with the help of the phaco needle, and keep the bevel needle down, just make one puncture, and there is a central puncture. After making this, the pressure is reduced. The phaco power should be 40, vacuum should be 300 to 350, and you should use the burst mode. But the problem I have faced is, one, the capsule is very fragile, and second, when you make the puncture with the phaco needle, the margins are very ragged. It is not regular like needle, so it is difficult. And sometimes, like in this case, another case, when you give the first burst, there may be chances of zonular dialysis because you don't know about the force applied to the nucleus. Then what is the main principle to, to prevent the Argentinian flex sign? Because intralenticular pressure is high, so there is a tendency of capsular axis to run away, and if you make first initial puncture, it hardly takes 10 to 11 seconds and there is a Argentinian flex sign. You are helpless. See in this video like this. So how to overcome this? Make a small central capsular axis in C shape. The vector forces act in the same direction, so they resist the radial extension of the axis. In a straight cut, like in this video, the vector forces acts in the opposite direction, so chances of radial extension is very high. And I used to give IV mannitol preoperatively to reduce the vitreous pressure, so chances of extension is less. This is capsular axis in the intumescent cataract, where it's rather a Morganian cataract. You just give the puncture and see the whole fluid has obscured your vision, and so remove this with the help of the needle. Use good viscoelastic, and after making the first initial incision, you can do the axis very well, even with the cystitome, like in this case. This is also the video of the two-stage rhexis. Same, but here I perform the rhexis with the help of the micro-rhexis forceps from the side port. So it is more controlled rhexis. Now in the Morganian cataract, the cortex gets degenerated and liquefies the moment you puncture it, and the nucleus floats. So there is no support to your capsule from behind. See in this case, everything comes out. Then with the help of the you remove it and again take the micro-rhexis. For see the nucleus is going here. So there is no support, and even you can put little bit viscoelastic in the back. So rhexis will be easy. And you should be very careful because capsule is fragile, thin and slippery, and zonules may be compromised. So one should be careful, otherwise there may be zonular dialysis and you will be in trouble. This is a case of traumatic cataract where there is a subluxation here, and I always start the rhexis away from the subluxation. It is difficult to lift the initial flesh because of the lax capsule, and one point to be remembered in this case is you have to take the central point of the lens, your decentered lens, rather than the center point of the pupil. Otherwise, there may be chances of decentration of the lens or the like this. This is the capsular axis in the pediatric cases. As the anterior capsule is very elastic, the zonules are very tight, and there is a vitreous upthrust, so chances of extensions are very high. Staining of the capsule not only reduces the elasticity and helps in achieving the perfect capsular axis. So even with the, and then again I took the micro-rhexis forceps from the side port, and we can complete the rhexis in a. Now nothing I mean to say in the capsular axis in the posterior polar cataract, so do not overfill the anterior chamber with the viscoelastic because there may be pre-existing PCR, and rhexis should be of adequate size. In a small rhexis, nucleus handling is little bit difficult, and if there is a PCR during the phaco, the chances are very high. So if the rhexis is of adequate size and small, we can put the lens into the sulcus. So this is all. To summarize, capsular axis requires a balance between the centrifugal forces applied to the anterior capsule by the surgeon against the centrifugal forces from the zonules, which tends to diverge the tear towards the periphery and the force of the lens material as well. With meticulous attention to the technique and balancing all hydrostatic and mechanical forces on the capsular bag, capsular axis can be achieved in a complex cases. Thank you very much.
Thank you, sir. In addition to this, if there's an intermittent cataract young patient, you can always see and appreciate the vacuoles. And IOL Master nowadays can also show you entire lens thickness where you can appreciate the same vacuoles. We also do consider doing yak cap preoperatively, as well as if the age is more and the vacuoles are less, then what Dr. Husband showed as lens massage, we do that preoperatively.
Yeah.
So if the age is young, vacuoles are more, and you see that on OCT picture of the Iron Master, we do a pre-op yak cap as well.
Very nice presentation and video, sir. A couple of things I want to say for beginners is, if you're going to do a rhexis from the main incision to a rhexis forceps, so always loosen your speculum. Speculum is one factor which presses on the globe when a vitreous upthrust occurs. One is that, and secondly, you should never stop in the subincisional area. The moment you stop in that area, the flap comes out, and then you are in trouble. So either stop short of it on left side or on right side. So these are 2 points. And thirdly, if you are expecting a complication like a posterior polar cataract, you can either make oval rhexis or make a slightly smaller rhexis, because you might want to capture the IOL if you are going to put a 3-piece IOL. So these are few of the points we teach our fellows. Another thing is, you can also do a phaco in a small rhexis, put in the IOL, and then enlarge the rhexis, so it's always safer. If at that point, even if it extends, you're still safe, the IOL is already inside. So, nice presentation.
Thank you, sir.
Oval rhexis is very useful,
Yeah.
I think, in the posterior polar cataract, because it is very easy to remove the sub-incisional cortex also, and doing the vitrectomy from all the area, and we can easily put the lens in the oval rhexis. Even capture of the lens is also
Done.
easy. So
Thank
very nice presentation.
Thank you, sir.
Thank you, Dr. Gupta. Do
Any
we have
questions? We are having 4-5 minutes remaining.
Dr. Pushpa Kumari is here with us? I'm here. She would be talking about a very important topic of ocular surface evaluation and optimization prior to cataract surgery. This is a step which we miss in our routine practice.
Respected chairperson and my colleagues, after a long discussion about the biometry, then how to select a patient and how to do a perfect surgery and how to do a capsulorhexis, but still we have performed a very good surgery. Next day, if you ask the patient, he will say, मेरे आँख से पानी गिर रहा है, I am not feeling well. तो आपका पूरा परिश्रम गलत हो गया. तो what we have forget here? The moment a patient comes with defective vision, we suddenly jump into the जाओ biometry कर लो, और we most likely to forget the ocular surface, जो कि it is the most exterior part and which is subject to lot of stress and contamination also. So that's why I have chosen this topic, though it is not important for all purpose, but for me it is very important. So careful assessment and management of the ocular surface is vital for optimal post-operative refractive outcome. The air-tear film interface is the highest index of refraction. It interferes with the pre-operative measurement if it is unstable or suppose there is any presence of corneal pathology. Often it gives rise to some refractive surprise, and it is the most common cause of the dissatisfied patient after cataract surgery, more often following premium cataract surgery. So these are the pathologies. So most likely we include this one, pterygium is most common. Then these are the dry eye, and these are the also some nodular degeneration. This is very rare for OSSN. So how image seen in normal and dry eye, we must know, and we must ask and with modulate the patient also, so that he can say and we also diagnose. So in case of perfect ocular surface, we will see very crisp eye image. But in case of the dry eye, patient will see, but it is very hazy. So what are the predisposing risk factors for ocular surface disease? We must know. So there are certain local factors and there are certain systemic factors. Among that, there is something systemic medication, Sjogren syndrome, contact lens user. Suppose a patient is a contact lens user, the same day we will do biometry, it will give wrong. So we have to consider that. Prior refractive surgery, concurrent use of other ophthalmic medications. So how I approach the ocular surface before cataract surgery? So first important procedure is slit lamp examination of the anterior segment before jumping for the any biometry or any posterior segment. Before any eye drop and procedure, means we have to do these procedures like in-office mammography, topography, ocular surface analyzer and biometry. Ocular surface analyzer and in-office mammography, we often, everybody don't accept, but if possible, it is better. So, focused clinical evaluation means first we have to see what are the periocular area, lid and lacrimal drainage. If any lid abnormality like blepharitis or any ulcerative or lacrimal, suppose epiphora or dry eye, and conjunctiva means lip cough, that's external dermato, that will give rise to then cornea and tear film. So these are the figures. First, this is the upper part, this is showing normal meibomian gland, this is the shortened, and there is total loss of the gland. And we have to go for topography. For the crisp layer, it will give both anterior and posterior. Suppose there is a dry eye level, it will give irregular keratometric reading. So optical biometry is best after. By using ocular surface analyzer, we can go for non-invasive tear breakup time. It gives a very good result. But we often go for Surmer test. We often neglect this non-invasive TBUT. And in OPD, we usually go for fluorescein, but it is not a good job. This is a very good technique, that is the LLPP technique for ocular surface analysis. Means L for look, to look for the blink rate, what is the lid lashes positions and health of the lid lashes, then interpalpebral surface, then lift. By lifting the upper lid, you to examine what are the position of the palpebral, bulbal conjunctiva and superior limbus. Then pull. By pulling, we have to assess the lid laxity, whether it is a horizontal or vertical lid laxity, or there is any floppy lid, or what is the position of the fornices. Then, by pushing, we have to express the secretion of the meibomian gland. So, it is according to the ASCR algorithm, so we have to follow this LLPP technique. Always evaluate both eye. Suppose a patient comes with one single unilateral cataract. Though we know we have to measure both eye, but still many of us are not measuring. So this will give, so always measure visual acuity of the both eye, keratometry, biometry, ocular surface evaluation, cataract assessment, then go for the posterior segment evaluation. Then I will tell what is the relation of the pterygium and biometry. Pterygium causes significant change in keratometry reading that ultimately affect the calculated IOL power. It is pronounced with the increase in the size of the pterygium, so management of pterygium before cataract surgery is must. But there are two schools of thought. Here, topography showing a large nasal pterygium and the resulting irregular astigmatism. So topography is better modality than the keratometer for the astigmatism. So there is a question arise, should we go for simultaneous or sequential surgery in the eye with the pterygium? If there is a small pterygium and cataract and it is not affecting more than 0.75 astigmatism, we can go for the simultaneous surgery. If the size of the pterygium is 3 mm or greater, we have to excise before the cataract surgery. And often there is a confusion, what is the waiting period? Most of this, they say 6 weeks to 8 weeks, but ideally it is 6 months, 3 to 6 months is required for the keratometric stability after the pterygium excision. So when, as we know, cataract surgery is a planned surgery, it is not emergency surgery. So why to hurry? So it is better to wait for 3 to 6 months after pterygium excision. So prior to dry eye, actually we don't, maximum there are pre-symptomatic eye, so we have to manage the dry eye also. This is a flow chart for the dry eye management for the cataract surgery. If during dry eye evaluation it is found abnormal, then we have to optimize the ocular surface. Then again during the cataract surgery, we have to protect the surface by giving low illumination, also repeatedly use of the visco, and also you have to go for the post-surgery management of the dry eye. If it is normal, then go for the routine cataract surgery. So to conclude, assess dry eye before cataract surgery. Cataract can cause new DED or worsen existing DED. In most of the cataract case, the 75% they are asymptomatic. They develop after cataract surgery. So we have to find out, we have to catch out that pre-asymptomatic dry eye. So improve ocular surface before surgery, get systematic disease under control, precautionary intraoperative measure to reduce the trauma to the ocular surface. So while it is not used, while we are not doing anything, suppose during lens loading or other thing, so I used to switch off the light. Post-operative medication to reduce the dry eye disease, staged approach in eye with the cataract and ocular surface abnormality is very essential. Thank you. Any question?
Excellent presentation, ma'am. You have hit the nail when you said myomitis and other management is very important prior to surgery, because if you don't manage it pre-operatively, then you will see the results interoperatively with all the muck floating around in the your surgical field. Not only that, your low class and other things are very important. Thank you, ma'am.
Thank you.
Any questions we have? Anybody has any questions? Actually, if you are going to do premium IOLs, three things you must look is the ocular surface, the pupil size, and your macula. If you are going to do multifocal IOLs and you have unstable ocular surface and you are going to put in an IOL which is further going to compromise the contrast sensitivity, you are yourself in trouble. Patient is not, he's going to come and ask you again and again. So that is very important. Secondly, sir said about MGD. So it's not only a problem with the vision in the post-op, the flora itself can get in and cause endophthalmitis. So it's very important to treat an MGD, and a lot of people I see they write mild MGD and go ahead with the cataract surgery. MGD is MGD, it's not mild, moderate or severe. So you need to treat it first and then do the cataract surgery.
Right. And even like ma'am presented and showed a point of autologous serum. We as a clinician, we should have our pharmacy all ready to make autologous serum in-house. It's a very small machine. I was surprised it was costing only 2,500 rupees. A small machine can make autologous serum in a house, and your dry eye practice simply changes. Nobody in your vicinity or in your town might be giving autologous serum. Initially, for a few years, I used to tie up with my pathologist, who used to make it for me. But when I realized that it is just for 2,500 rupees, that small centrifuge, and now we are making in-house, and the same money which he used to give to the pathologist, wait for 2 hours for the serum to come back, we are able to do it in 15 minutes time with the same staff which we have, no additional expenses as well.
You rightly said the main purpose is to classify the dry eye. If you are dealing with an inflammatory dry eye, lubricants alone are not going to help. You need to add something else like a cyclosporine or something else. Yeah. Thank you all. If you have no more questions, we can just have a group photograph with the participants.